Welcome back to the Chief Healthcare Officer podcast. I have been looking forward to this conversation for a while. My guest today is someone whose work sits right at the intersection of everything I write about in my book, Connected Care. Technology that reaches to the patient earlier without ever losing the human relationship at the center of the care. Dr. Saria is the founder and CEO of Bayesian Health, and just a couple weeks ago, Bayesian and then Mayo Clinic announced a code-developed AI solution aimed at getting patients to palliative care earlier with real validated impact on readmissions. Dr. Saria, welcome to the show.
Thank you so much for having me, Dr. Gul. I'm so excited to be here.
I have been really looking for this episode, Dr. Saria, because the things what you have created earlier and the things what you're trying at the moment with Mayo Clinic, with Cleveland, and the others, these are something eye-opening developments for us because we are now having this something called AI, which is a super robot. And then everyone has been looking for using this in the right way, and then everyone has their own use. I mean, my daughters, they use it mainly for negotiations with me if they, in case they want to buy more makeup stuff or the toys and the other thing. And then our doctors, they're trying to use this in different ways. So now when I heard about your story with the Mayo Clinic, it actually was a great signal for me. And then it was impressive to see someone is really bringing this super robot for the benefit of the patient. So that's what we want to discuss with you. But then, just before jumping into the conversations, you have spoken before about the personal loss that pushed you from academic research at the Johns Hopkins and then into the Bayesian Health you just started. For listeners meeting you today for the first time, how did that experience shape the kind of company you set out to build?
Yeah, absolutely. I'll go back a little bit and give some background on myself. Um, I am the founder CEO of Bayesian. I spun Bayesian as a company out of Johns Hopkins. I also am a professor at Hopkins where I hold an endowed chair and work across AI and health. In my time at Hopkins, over the last decade and a half, have led a lot of research, all the way from advancing the core technology of AI itself to its applications in lots of different areas, from critical care medicine to neurology to autoimmune diseases, all funded via Center of Excellences in the US, funded by NIH, NSF, DARPA, CDC, and also the FDA. And you know, um, I was working very hard, had a full-time job, had plenty to do. It was a very busy researcher professor life, and didn't need yet another thing to do, if you will. And in our research, the work we were doing was showing. I started on this journey relatively early, and a lot of my lab and institute's research focused on how can we use AI on the kinds of messy, dirty, biased data sets we see in electronic health records and build applications that are reliable and robust that can be delivered at the point of care to do all sorts of valuable useful things like early detection of harmful adverse events, finding ways to do precision dosing where that makes a huge difference in outcomes, finding ways to monitor patients at home. And we had really implemented some pretty exciting areas. And in particular, in sepsis, I had done work showing how sepsis is example of a model complication like many others where basically it's a failure to rescue type situation. Like patients will slowly deteriorate or decline, and people often miss it because it looks like a lot of other things, or you anchored on something else and you don't notice it. And unfortunately, as you know, as a physician, the decline happens very rapidly, and an hour can be the difference between life and death. And that's unfortunately what happened to my young nephew. He was recently married. He had gone out with his wife for an event. Next day he comes back, he's not feeling well. He's admitted to a hospital in India. It was a good hospital. And he caught sepsis, and they didn't realize He ultimately ended up in the ICU with septic shock, and that's when I got the phone call, and it was unfortunately too late, and we lost him. And that moment, I distinctly remember feeling like it was kind of wild. Like my parents called me, and they had seen me publish a lot of work on early detection of sepsis. I'm probably the only other person they knew that knew anything about sepsis. And so they said, "Don't you do a lot of work in sepsis? The doctor is saying this person, like, he has sepsis." It basically made me realize we had made huge advances in research to show how state of the art AI, when implemented correctly, could do a lot for improving early detection in patients. But we had not been able to translate this technology. And until we did that, we weren't going to see benefit. So that's really what got me to start moving my work into understanding the translation. Like, how do you deliver this in a way that physicians will trust? How do you deliver it in a way so it's easy to use? So that not just a Mayo or a Cleveland, but literally any hospital in the world can adopt this technology easily and readily and bring this kind of benefit to patients. So that's what led to my journey of Bayesian Health, Bayesians. And just a couple sentences about Bayesian, it is now, it's been quite the journey. We've now partnered with many health systems around the country in the US. Um, we're both at academic and community and regional sites, so lots of diverse settings, almost 25 million patients um, and more. So, like at scale now. And what was really fascinating, and what it does is it's basically a real time clinical intelligence layer that's deeply embedded within the leading EMRs in this country, Epic, Cerner, Allscripts. And it provides clinicians with real time signals that help them act proactively instead of reactively. So, identify patients in need for conditions that are highest drivers of mortality and utilization for health systems. So essentially, in a whole host of conditions, we're identifying the signal early when there's an opportunity to intervene, and then connecting these with AI powered workflows that make it very easy for the care team to understand why was this patient flagged. They can transparently see why. There are workflows that make it really easy for them to do all the follow ups and save them time. And that's what's allowed us to drive the outcomes.
We will come there. I mean, I just want to discuss and understand more about the Bayesian approach for such things. I mean, as a physician, we have been trained in the medical school to capture the data about the symptoms, about the test results, and then reach out to the diagnosis decision and provide the prescription based on the medication use or the procedure. Again, we collect the data, and then we just want to follow and monitor the healing process. So when you look at the medicine, it's all about actually data management. But as a human being, and also with the demand and then increasing job load, we have so many patients. There is no single human has actually kind of a brain who could capture all this data and then capture the changes here and there. A while ago, we had a guest actually from San Francisco, and then he was telling me that it is no more the dashboards for the hospital, and then he was trying to create kind of a central nervous system for the hospital which will have the reflex, just like what you have explained, even before the clinician reaches out and then makes the decision. Some decisions could be taken easily by the system itself, and then later on some decisions need some conscious review. So then I think what we all need is to bring all this data in a, I mean, useful way, and then turn this into decision. So I appreciate, I mean, your word moving from the reactive to the proactive care, and then taking this into the operation. But do you think the hospitals in US and around the world, or the clinicians, are they ready for this kind of, I mean, transition? What kind of operational mindset is required to catch the Bayesian speed, if I may say?
Yeah, absolutely. So I'll start with some examples because it's almost easiest. because AI can feel futuristic, but it's actually quite easy if built in a way that feels familiar, easy to use. So one really simple example is I spoke about sepsis, right? Leading cause of hospital deaths. In the last 5 years, as awareness has grown for sepsis, at least in the US, or 8 years, through electronic health records, people are used to building like simple alerting rules or best practice advisory alerts, or BPAs, they're called. So they're used to the idea of like an EMR sending like a flag or like, an alert, a pop up in the patient's chart when you show up in the patient's chart. And so the notion of some electronic approach of pinging you and telling you things is not completely unfamiliar. The challenge is the way it's been done today mostly leads to alert fatigue. People don't see them as helpful, they mostly see them as hurtful, and they mostly ignore them. So the idea was to say, okay, what if we could take all the data in the background, not just a small set of and create some simple rules with a small set of data elements, but really create a longitudinal record of this patient. So we really understand what is normal and baseline for them from this encounter and past encounter. From that, we can start to model and learn from millions of patients. We can learn different ways in which sepsis can present in different subpopulations, right? Whether someone has chronic kidney disease, they're going to look a little different, or someone just had a major surgery, they're going to look a little inflamed, so they're going to look a little different. Someone who's a young adult, they're going to be otherwise healthy, they're going to look a little different. So from millions of records, we could really learn pretty accurate, turns out, markers for how these evolve in different subpopulations. And then in real time on this patient population, we can start to index if this patient is at risk. And if they are, then you can start to show up in the patient's chart in a very beautiful and elegant way. Like, for instance, they're used to patient lists where you can, instead of having a pop up that only shows up when you're in the patient's chart, you can show, information that signals as to who and also why. The why is now not unfamiliar AI. It makes it very easy to say, instead of doing 13 clicks across a chart to figure out what this patient's history is, we're pulling it all together to make it really easy to understand the context about why this patient. As soon as they see that, it's you can do an evaluation very quickly. So in other words, it doesn't seem futuristic AI. It's pretty straightforward. Something's running in the background. It's telling you why this patient is at risk. Then there are agents in the back working to summarize the data, pulling the data, summarizing the data, presenting a quick workflow where you can agree, disagree. If you agree, it connects you with the follow up steps like the right treatment pathway, and it proffers you up with the right documentation with all of the clinical criteria like that were relevant so that you can quickly summarize. So you can really move your attention back to the task at hand, taking care of the patient, not all the administrivia that is needed. And then let's say you did something and something was lost, you can come back to it because it sends you nudges. So what I'm describing here is when people think AI, sometimes they think robots or sentient beings or something really, but here this is really, it's working for you. It's taking all this data, it's making it really easy to do the right thing. It's removing all that alert fatigue, that noise. It's seamlessly presenting information where you would have been in the first place, flagging you when maybe you a critical moment that you missed. And when we first introduced this, back in 2018, it wasn't that immediately clinicians adopted. We had to do a lot of learning on how do we, a lot of work on both the signal itself as well as how it's presented and how it's delivered and how it's implemented to drive adoption. What's been fascinating to me is in the last, like, now every single site we've ever implemented, we've gotten 85 to 90% plus adoption within 6 months. That means
Amazing.
every time a patient is
That's
flagged, providers go
amazing
seek it
speed.
out.
Wow.
Yes, every single time. And that's what makes it so exciting, that it's not just like cool AI. What it matters is our clinicians, then it does work. We published some papers on the cover of Nature Medicine in 22. These were massive, massive trials, 750,000 patients across 5 sites of Johns Hopkins, academic and community. And we showed first, at a place like Hopkins with very high quality, the ability to identify these patients a median of 5.7 hours earlier. That means more than 50% of the patients, there was 5.7 hour room over clinicians at Hopkins.
You're simply saving lives with this, approach. Before we were calling such things as the machine learning, and then you got all this data. Now you're adding this super robot on top of it to bring all data together and analyze it, and then take this into an position which you can make decision, and then you can move forward. So, Dr. Saria, it's amazing story, but then I just want to get into the update, the news with the Mayo Clinic. Mayo Clinic and your company has announced this co-developed AI solution, which you have been identifying the patients who could benefit from the palliative care earlier in their stay. I think you simply have implemented the sepsis approach to the palliative care approach to catch the patients earlier. Could you please walk us through what kind of platform is this, and then what signal is it picking up from a busy clinical team, which might, or otherwise miss this? So, can you just take us through the process, how it works, and how did you reach these great results?
Absolutely. So I'll just give a little bit of background on the results. So just like we've been doing, the platform, like I said, the same approach is applied to a whole host of areas. Here with Mayo, we partnered on implementing a new approach for proactive palliative care. What we did here was effectively, so just going back a little bit, Mayo has some amazing experts who had done a lot of like over like almost half a decade, done very, very nice work in palliative care in finding ways to um, close the unmet palliative care need gap. And the thing they were finding was that threefold. First, they were seeing that there were a whole host of patients. They had almost 200 beds worth of capacity in the system with where was where patients were with advanced illness were returning, and they were returning over and over again. And when you look at like you do chart reviews to understand these cases, one in two of them would have dramatically benefited from proactive palliative care because they were, often when patients are showing up, the care team is very busy doing exactly what they need to do for the patient that's in front of them, not thinking about the history, not thinking about how they got here. Because often there's not enough time. Also, um, you know, uh, it's hard to make sense of like, well, what does the patient want, especially if they're near end of life and there's a question of like, what is their want? What does their families want? These are often difficult situations where having these hard conversations isn't easy for everybody. So the whole purpose here, and there's lots of literature showing that, if you can give patients goal concordant care, they're happier, they're satisfied. For families, it's better. So what we did here was that Mayo, in their own research, had shown that they could use algorithms to identify patients markedly earlier than they were doing without it. And they had implemented an early program that they had implemented at one site and were seeing some really beneficial results. So they already had understood the value of doing things differently. At some point, 2 years ago, they reached out to Bayesian to say, we really would love to bring this kind of approach to Mayo. And so then we partnered to say, how could we take their expertise, depth of expertise in palliative care combined with our expertise in operationalizing and scaling systems like this to build something that really was easy to use, scaled, and really patient centered. And so, same thing, just like I described in sepsis, we integrated the platform with the electronic medical record. It is analyzing every single patient across we started with the Rochester Mayo site, which is their flagship. There, it's looking at every patient. And what's really interesting here is the ability to look at this encounter and past encounters. So you can look at a patient's clinical history, their chronic comorbidities. You can look at also the acute development, how they're doing, but also the utilization, right? Like, what has the pattern been? Are they bouncing around a lot, which means they're not getting the care they really need? All of that then informs this patient's picture. And for Mayo teams, what was really fascinating is suddenly they were able to get a full live heat map across the system. of where are these patients today in real time who would benefit from proactive palliative care, where previously they were essentially, um, like they were heavily reliant on the attending or the team that's caring for the patient to initiate. So often these patients wouldn't get the care they need in the first place. So as we did that, we were able to see first, like for the pal care teams, they were able to now have, they were able to scale their care across the system much more efficiently. Second, for the clinicians at the bedside, for them, we provided a care coordination workflow that made it really easy. So you didn't feel like somebody is from on high coming to your patient and doing things to you. There was a coordination model. And then what we found were a huge increase in like, the number of the right patients were getting consults much more often than they were before. We also saw nearly 25 to 28% reductions in 60-day and 90-day readmissions. And very recently, as they tallied the length of stay data, we also saw nearly a 5 day reduction in length of stay. So just like a lot of different, uh, key metrics getting impacted from not just improving care, but also the system starting to see how this is, impacting them.
But then this will never work unless you can build the trust with the clinical teams, and then clinical
Absolutely.
teams should be part of it because I have been hearing so many different implementations, even in my hospital. I mean, some of the vendors they come and then we try to implement, but then if you can't have the gel between the solution and the clinician, you remember, I mean, when you say the sepsis predictive models, you take me to the COVID times. I mean, there were so many companies that were coming to us, EICUs, collecting the data, and then they were saying that we can, give you the prediction much, much earlier and so. But then, if the clinicians did not work together, it didn't work. How did you achieve this? I mean, to reach to 25% reduction in 60-day readmissions or 28% reduction in 90-day readmissions, these are miracles. I mean, it is striking. So, how did you reach to these numbers, and how did you get this clinical collaboration?
Yeah, I think I'll go back a little bit in history to explain how we got there, because this was probably one of the hardest problems we needed to solve. So back in 2018, when we first went live with our system in sepsis, literally the first quarter when we implemented it, we partnered closely with one of the key sites at Hopkins and clinical collaborators to develop it, implement it, and we saw basically only 2 physicians used it. It was so disheartening because you felt like they were our collaborators. We worked on it together. They know how beneficial it is because we had already used the data to benchmark how the system was much more accurate and would dramatically improve performance on their patients. But the reality was, as a technologist, we often underestimate the complexity of what it takes. You're often not there are so many ways in which things can, where there are gaps or barriers that prevent use. And that was sort of what started my journey down this area of not just focusing on the AI technology, but really focused on what's called human machine teaming. That's this area of research, or clinician machine teaming, which is how do you design systems in a way that the clinician, the machine, can be more productive and effective together? And in doing so, we had to think a lot about the science of behavior change, and like how do clinicians build trust. So in 22, one of the big papers we wrote was on mental models for trust building, and we studied what are clinician mental models for trust building. And turns out there are many levers for trust building, and not all clinicians use the same levers, which means in order to solve the problem, it's not good enough to do one thing. You have to kind of close the gap in a variety of ways. And so, in designing the system, we kind of went down this path of closing the gap in a variety of ways. And essentially, I'll give you a little bit of like some example ideas, though this itself is now a massive research agenda we went down. So, first is like, how do you build a system that is adaptive, listens, is responsive? Because historically, alerts would, like in the same patients, you would say, no, this patient is not septic. When the same criteria were met, it would keep banging. Well, that doesn't sound like a smart thing. That sounds like this thing is pretty dumb. So if you can't listen, I'm not trusting you. So this ability to listen was very important. So with all that context, we were able to intelligently program it where it adapts over time to a patient and it's learning. That turns out is a very good, useful trust builder. Second was black box versus glass box, the ability to show context for why in a way that makes sense to a clinical user was extremely important because now it's not just, just believe me. Well, why should I believe you? So that's another example of trust building. Third, when you're supportive, you tend to trust people who support you. So, for instance, rather than solving the narrow pain point of like, I'm going to just shove up a pop up when you're in the chart, you're actually going to help me take better care of my patients. And in order to be supportive, we incentivized adoption by putting the before, the during, and after the process. So, before is summarizing the data, collecting all that, saving you time. During is providing all that summary. After is all the follow through work. You're making it easy for me to do. So, you're providing me a lot of value in a way that I can see this is useful for me. And then there is evidence. Evidence generation is a very core part of how clinicians build trust. Second, peer-to-peer learning. If a trusted clinician who's an expert tells you this thing is very good, then many clinicians who are late adopters will adopt trust that way. Or experiential learning, which is you interact with it and you learn over time because you collect your own data with it. So all of these different widgets had to come in, not just so some of it impacted the design of the software, some of it impacted with our approach to how we brought the technology to market by we stayed in stealth mode, did a lot of research studies, partnered with the FDA to get approval. We announced 3 months ago approval for our work, which was the first ever continuous monitor to be approved by the FDA for this kind of early detection. And it took 3.5 to 4 years of collaboration with the FDA to do this because it was novel in so many ways. And then, again, trust from lots of case studies and results that they continuously see. And then post go live, we are instrumented to record and we do a lot of reporting. So we monitor patients kind of when they were flagged, what happened, how quickly they got what they did, what was the outcome, where did they end up. And then we use that very granular data to surface up insights on where there are care gaps. Why? Why did it happen, not happen? That kind of learning really supports experiential learning. It's almost like think of it as M&Ms on steroids because you're really kind of learning in your patient population how to adopt.
You're simply explaining this to me as a researcher, and I really love the mindset and the thought process here. And I really appreciate your patience because even in the same hospital, sometimes one department says it is sepsis, and the other department says it's not sepsis. And for that reason, you need to check what kind of data they're creating. And we had, let's say, problems with the denominators. Some of the departments, they were having a different kind of denominator, and the other department has a different denominator, and they're the same patient, they have two different outcome data. So later on we had to create something called data warehouse, and then we just fixed all the understandings of these reports, so then we don't want departments to confuse themselves. And you're dealing with multi clients, multi hospitals, and you're dealing with the hot shots. I mean, you have Rochester, the Mayo Clinic over there. I mean, you have great people who will challenge you. And on top of that, you have also the insurance, the payers, Medicare, the medical legal issues. So having all these things and the challenges, and at the end you reach to these kind of outcome, I really appreciate your patience and then your resilience, what you have created, Dr. Saria.
Thank you. Yeah, it's definitely been a journey, but it's been very rewarding to see.
I can see
Um,
this.
I think ultimately, when we think about other areas of medicine for making anything the standard of care, it's taken a lot of work, right? You have to change so many
100%.
hearts and minds. And it's not like, social media or something like that. Like diffusion of innovation in medicine is like converting all the non-believers into believers. And part of that is, it's the adoption curve, right? The early adopters, early majority, late majority, and the laggards. And you've got to work through the adoption curve. And um, anyway, I'm very excited for this to become the new standard of care. And then as that happens, I'll be able to take a vacation, which will be very nice.
You're rewriting the standards. I can see this definitely. But then here I just want to jump to the next, chapter about the AI use in healthcare because you have been collecting the data. Now I think this is the best time for a company like Bayesian, where you have another tool like AI on top of what data you have created. You will be able to add this on top, and then it will create so many even unexpected results. So the thing what I want to ask to you, if you were advising a hospital CEO today who has a real budget for AI, but only one serious shot at getting the first implementation right, where would you tell them to start? And where do most health systems actually go wrong in AI use today, you think?
Hmm. So, oh my gosh, this is such a good question. There are so many pieces to this. Why don't I start with like common misconceptions? Because I think that will be so I think the part that they do have right is that what has changed in the last couple of years is they realize business as usual is not going to work. And you have to have a better strategy and a new strategy, right? And what I'm seeing the forward looking health systems then do is to really craft a strategy. And crafting a strategy really involves a couple different things, right? There's sort of the core of care delivery, which is how do I deliver better care to my patients? And for them, when you're doing that, there's, historically people used to think of, I'm just going to take the hospital senior leadership's hat, right? Where ultimately they want to do good by patients. But what I see, at least in the US, is there's also an element of like no margin, no mission. And it's become harder and harder to deliver care here because payment rates are declining. Patients are only getting more complex. Labor is getting more expensive because of shortage. So as a result, and they're feeling squeezed from every side. And what there's and as a result, there's been a shift from the mission, which is how do I take better care of my patients, to how do I survive? One thing that I am really excited about is that I think better quality also leads to better financial sustainability. In fact, quality is a strategy for financial sustainability. And a very simple way to think about this is you can't afford to have those patients, and you can't afford for your system to be not reliable, providing high reliable care reliably anymore, right? Consistently, because every time a patient has a complication, right? And there are 98 different complications we can think of: health, sepsis, pressure ulcers, all sorts of failure to rescue situations. We spoke about palliative care, malnutrition, all of these impact, huge impact on length of stay, huge impact on readmission rates. In the US, you're getting paid on the DRG. You get paid a fixed amount. But if your patient is staying there twice as long, it's bad for the patients. You're spending twice or maybe three times as many resources because these patients are often way more complex. And that's now impacting your ability to survive. So, if you had the ability to make it easy for your frontline clinicians to do the right thing in the first place and do it more efficiently and proactively, it's better for patients. Because take this example with sepsis, or you could apply this to any of, we talked about palliative care. Identify the case early. By doing so, you're taking what would have otherwise been someone who would have ended up in the ICU, you're taking care of them proactively, you're improving their outcome. They're going from someone who's an otherwise very complex, worst case from decline, to a less acute case. Patient does better, your providers do better, your clinicians do better because they're getting the support in workflow to do the right
And it will
thing
be less
proactively
costly.
and much less costly for the system. It's very rare. I feel like a lot of AI that I like, there's always all these games you have to play. And it's just very satisfying when you can just do the right thing and it feels good. And so this is one of those opportunities where I really feel like, many of us come into healthcare in the first place because we wanted to do right, right? It's not like some other field where the primary objective is making money. And so to me here, what's exciting here is the opportunity to do right by patients, right by your system, improve care while maintaining financial sustainability. Now, people also feel like AI for touching care is also risky because they feel, I'm going to touch patient care. That's high stakes AI. Maybe I should do some back office stuff. right? So there's been a focus on a lot of these kind of admin tasks like back office, coding and billing,
Non-clinical things.
non-clinical things. And that makes sense, right? Also from a mission margin perspective, focus, building a little bit of experience on the back office type thing makes a lot of sense. So there's opportunities there in prior authorization, there's opportunities there in billing and coding. And in the US, at least, people say it's bots fighting with bots. It's the payer bots fighting with the provider bots on who can code more or who can deny claims more. But nevertheless, I feel like that's another area where there's a fair amount of investment. So I'd say business as usual is not good enough. It's important to have a strategy. I believe the strategy needs to be rounded. It it can't omit patient care. Like patient care is at the core. It has to be at the core of the strategy. And because ultimately that is what gives you the long-term gain you need or long-term shift you need in your way of operating. And then finally, in terms of how you go about implementing the strategy, um, people also have this idea that maybe the way we're going to do this is we're going to like find a EMR or like one single vendor partner that's going to like, the foundation model companies or something, and they're going to solve it. But healthcare is so hard that I think you really need dedicated knowledge, domain knowledge, right? The tech alone is not good enough. You need to understand, the data, the complexity in the data, the bias in the data, technology, how it embeds, how it's going to impact the user, how are you going to measure if it's working, how are you going to iterate. So the ability to have partners that are experts in key areas is very important to success.
100%. Otherwise, I mean, it is an ocean. Every day we receive so many different emails about different kind of AI solutions, and then the people are trying to introduce their different kind of products. You will get lost. I mean, you have to make this strategy in the right way, and that is, let's put it in a way, a recommendation to our colleagues running hospitals today. As you also said very well, budgets are getting tight, and then the cost is getting higher and higher every day. Your margin is already, I mean, narrowed very much. So you have to be really careful in this, and you have to select the right partner, and then you can run it accordingly. So now, I mean, just before we move to the next questions about the, I mean, Health AI Coalition, and then the other thing, at this point, what is your plan for the Bayesian Health? I mean, you have touched to the point about sepsis. You are now in palliative care. Are there other, I mean, focus areas you're working at the moment, and you're trying to create other solutions for the hospitals?
Absolutely. So we've gone beyond sepsis to thinking about failure to rescue more broadly. There are 98 different complications that lead to patients where they can have sudden decline in a hospital and needing unplanned transfer to the ICU. We know in those cases mortality rates are much higher. And if you could have proactively identified them and given them the right supportive therapies, you could have avoided that decline in the first place. In fact, there's a Kaizen study that shows nearly 30% reductions in mortality when you can do that. So we have this work that we call proactive rescue. It's basically failure to rescue type scenarios where for, there's cardiovascular, neurologic, respiratory, and infectious. Those are the four big pathways that lead to these sudden declines. And for each of these, how do we identify these cases in the hospital earlier? So that's an example area that we've expanded to as seeing very, very exciting results. Um, Readmissions, again, there are 16 different reasons why patients can get readmitted. Palliative care, patients with advanced illness um, suffer from a lot of readmissions for a number of reasons. I said some can be mitigated via proactive palliative care, but there's also other things like someone with heart failure needs follow-up through heart failure clinic, or someone with fall risk, or someone with polypharmacy, or someone with social determinants of health that need very specific follow-up interventions. So that's another area where we're doing a lot of work. Hospital-acquired pressure injury, HAPI. Again, an area where, today nurses do head-to-toe assessments twice a day. Turns out only 8 to 10% of the patient pool is truly at risk. If you could have identified them early and given them the right interventions, not only is it better outcome for patients, imagine you're asking your nurses to do 10x as much work when a big chunk of it is low value. So you're cutting a lot of low value work out of there and allowing them to put their time when it really matters. So between these 5 or 6 conditions I mentioned, we did an analysis for a recent health system, a 2,000 bed health system, where we showed nearly 100 million impact on margin.
Amazing. Amazing.
$100 million impact on margin just from these conditions alone that we're working in.
That
And
is for the margin side, but I also want to add something to the benefit of for the patients. They will
huge.
receive less medications. They will leave the hospital environment earlier. They will get healed much faster. They will go back to their life much faster. So that's the biggest, I believe, gain out of all these things. And I really, I mean, appreciate, and it's an impressive outcome what you're doing.
I really appreciate you saying that because I feel like when I'm talking to hospital leaders today, I feel, for me, I got into this because of my nephew. I got into this because I wanted to make a difference in patients. And then very quickly I realized like my partners are in a very tough situation. So I have to make it easy for them to do the right thing. So it was all about making the value story clear, you know, to ease some of their pain points. And I love that you brought it back to the reason why we were all here in the first place, which is making it, you know, making making our care better, making the right thing the easy thing to do.
You're doing this already. So, I mean, we're about to close this, but maybe the last question, if I may ask, if a hospital leader today listening us and then wanted to take one concrete first step toward proactive AI-enabled care, let's give him or her an advice. What would you tell them to do this quarter?
I think the most important thing, like we do when we partner with our system leaders, is we start from looking at the data. There's a lot of data systems already collect that are reporting outcomes, through CMS, MedPAR. So we start by looking at the data to say, looking at your data, here are all the places where we see opportunity. And then from there, we say, then we think about a roadmap. So from here, you say, well, what would be a roadmap? You don't want to go on to the gym and on day one bench 100 pounds because that would be really bad. You want to work your way to 100 pounds. So we create a roadmap that really allows them to build up like the ability to succeed. Because when you succeed in the first area, that gives you confidence to take on the next and the next and the next and the next. I'll
Right.
close with one story. We were at Rochester. You mentioned them. When they have incredible leadership. We went to their chief digital officer, who is, a surgeon, amazing, very good hearted. And he was like, this is so sad. We've attempted to do this. We have an amazing team on our own. With the EMR, we've launched programs and they had done this in a few different areas. And they gave me an example because of, policy outcome. Sepsis has been an area. A lot of hospitals have tried a lot in with AI, with their version of alerting, etc. They went live twice over a couple of years, 1 to 2% adoption. They would call abject failure. And they said, I was like, look, we have so much data showing we can succeed. And we have evidence. We have proven clinical trials, evidence. And he said, I just think that maybe my clinicians are just cynical. Maybe we're in upstate New York. It's too cold here. Maybe they're academics. They're skeptics. There are all sorts of reasons why we may be very different. But he also said, we can't give up. It's so important. And so we partnered with them to come up with a strategy. And we started by measuring performance on the data, identifying some key critical areas, measuring performance on the data. We went live within 6 months, 85% adoption. So
Amazing.
exciting.
Wow.
So
From
I
one
also I
to 85%.
yes,
Amazing.
exactly. So I think a huge part of it is like it's like you have to make a good plan that starts
100%.
from looking at your data, understanding your environment, understanding the opportunity, and then effectively, implementing it in a way where you really are being social, culturally sensitive.
Great advice. Great advice. I mean, as a hospital operator, for me, every single item that we buy, I mean, say it is a new machine in the OR theater or the robotic surgery device or any other, even a small device, always the question in my mind is about the adoption. I mean, will it be really used? I mean, will the doctors use this and then will I really get the benefit out of it? And recently, there was an article in Financial Times about the Palantir AI. They implemented this for the no-show problem in NHS hospitals. Two hospitals did an amazing result, and then all the rest, there is no result out of it. And they are naming in the article, and then they're saying that, well, you know what? AI is not the solution. It doesn't work. Something like it's all about implementation. It's all about ownership. It's all about adoption rates, which we should gain. And the thing what you did, I believe, is much more important than the readmission numbers. If you can't get this adoption, it will not work in anywhere. I mean, in even the best hospital, we will not be able to see this. I'm really enjoying the conversation, but I mean, we have some limited time. Any closing thoughts you would like to leave with our audience of global healthcare leaders?
Um, I First of all, again, thank you for inviting me. I am so delighted to have this conversation with you and discussion with you, and hope we'll stay in touch. And in terms of, I really hope in the next 3 to 5 years, leaders will change their mind where they won't just see the use of AI as yet another gimmick to do the coding game, right? They'll use it to bring it back to, again, why we were all here in the first place. Our providers need it, they're burnt out, and they need ways to make their lives better. Our patients absolutely need it. And you know what? Done right, it can even make your life easier. It will make going back to work every day. I say bring back the joy of practicing medicine.
Dr. Saria, this has been exactly the conversation I was hoping for. Thank you for the great work you and your team and the hospital teams that you have been working are doing to make this real inside the hospitals. And thanks for taking the time to walk us through today. Thank you so much for everything, what you do for saving the lives.
Thank you so much.
Thank you.